Thank you for having me here. And thank you to the cardiovascular and translational vascular medicine team that I'm representing. Today, I will present our project and some preliminary data on the DADA2 patients that we have enrolled to date. What we already know about the DADA2 is an autosomal recessive disease resulting from loss of function mutation in adenosine deaminase 2. This audience may be familiar with this bar diagram that illustrates the most frequent manifestations of DADA2. They present with different frequency and different severity in different patients. What we will be studying are the vascular manifestations of the disease that are also heterogeneous. I have here highlighted the most frequent vascular manifestations that include the livedo racemosa, the panarteritis nodosa, the digital necrosis, subcutaneous nodules, and Raynaud phenomenon. Of course, the very important neurological vascular manifestations, including the large ischemic strokes, the lacunar strokes, and the hemorrhagic strokes. But virtually any vascular bed may be involved from the vasculitis of the DADA2. We have observed stenosis and aneurysms in multiple vascular beds, and we may have found them incidentally or because of clinical presentations. We also know about the pathophysiology of DADA2. We know that the deficiency of DADA2 enzymes disrupt the vessel wall integrity. It causes a dysregulation of netosis, chronic neutrophilic activation, and the polarization of the macrophage population with a predominance of M1 population causing a cytokine imbalance. This causes inflammation. With the inflammation, the endothelial damage that leads to medium or small size vessel vasculitis. And we also know about the pathology, mostly through skin biopsy. We know that there is a necrotizing non-granulomatous vasculitis with fibrinoid necrosis, leukocytoclastic vasculitis, and or panniculitis. What we are doing at the NIH through the NHLBI project, we want to further delineate a cardiac and vascular phenotype. We are using exclusively non-invasive methods to identify early or subclinical characteristic vascular abnormalities. We want to be able to recognize and monitor the patients before the development of possible catastrophic vasculitic events. After we define a phenotype or multiple phenotypes, then we plan for study correlation of genotype, phenotype, and phenotype with DADA2 levels. Our study includes both cardiac testing and vascular testing. The cardiac testing includes merely clinical testing, electrocardiogram and echocardiogram. The vascular testing includes some tests that are mostly clinical and some that still have their niche into the research world. So we are performing ankle brachial index, digital brachial index, nail fold video capillaroscopy, laser speckle contrast imaging, endopath, near infrared spectroscopy, and eye evaluation. And I will go into the details of this testing. To date, we have enrolled 9 patients, age range 15 to 58. 5 of them are female. 8 of them presented with the livedo racemosa on exam. 6 were diagnosed with panarteritis nodosa. 6 had skin nodules at some point in time in their life. 1 had significant skin ulcers. 4 patients had a Raynaud of different severity, with 1 of them requiring amputation. 3 patients had history of strokes, and 4 patients had bone marrow failure. From the cardiac studies, we performed electrocardiograms looking for ischemic or cardiomyopathy changes, conduction abnormalities, or arrhythmias. To date, we have found no significant abnormalities in the patient enrolled. We also performed echocardiograms. With the echocardiogram, we are looking for cardiac structure and function. We are looking for the strain, illustrated in this figure below. looking for subclinical abnormalities that may be an indication of small vessel disease of the heart. And we also screen with the echocardiogram for pulmonary hypertension, again, investigating one more vascular bed. To date, we have identified no significant abnormalities also in the echocardiogram. Going into the vascular studies, the ankle brachial index. This is the ratio of the highest systolic pressure at the ankle to the highest systolic pressure in the arm. Here you see a figure of one of the tests performed where we obtained a nice waveform at the ankle associated with the numbers that we study. The digit brachial index is the ratio of the highest systolic pressure in the digit, that is the upper or lower extremities, to the highest systolic pressure in the arm. Here we have two examples, one normal with nice waveforms in all the digits of the patient that we compare to one of our abnormal studies in the DADA2 patients affected, where we can see a flattening of the curve in most of the digits. And this associates with the numbers that are abnormal. And here we see the ABI reflect abnormalities of the large vessels. Now, with a normal range between 1 and 1.4, all the patients in our cohort had normal ABI, underlying the fact that most likely their large vessels are in good condition. On the other hand, the DBI, where normal value is above 0.65, revealed that multiple patients had abnormalities in both the lower extremities and the upper extremities. The patients that had the abnormal digit brachial index are the ones with the stronger vascular phenotypes, are the ones with the Raynaud, the ones with the amputation. So the DBI correlates well with the clinical manifestations of the disease. The nail fold video capillaroscopy. This is a non-invasive imaging technique that allows for the detection, characterization, and quantification of microvascular abnormalities, both morphological and functional, through the direct visualization of nail fold capillaries. From this image, you see how the test is performed on the 4 fingers of the hands using a scope that is exactly the one that we use at the NIH. In normal condition, the microvascular pattern is characterized by a regular array of microvessels with large intra and inter-individual variability. The understanding of the nail fold video capillaroscopy results from years of research in the Raynaud phenomenon, where it has helped to distinguish between primary and secondary Raynaud. It has helped to monitor the response to treatment. But then the nail fold video capillaroscopy has been extended to other diseases, more rheumatologic diseases, but also hematologic diseases and arterial occlusive diseases. When analyzing the results of the nail fold video capillaroscopy, we perform qualitative analysis, semi-quantitative analysis, and quantitative analysis. The qualitative analysis is pattern recognition and description of the global microvascular architecture, shape, and distribution of the capillaries. With the semi-quantitative analysis, we look for giant capillaries, microhemorrhages, neoangiogenesis, and capillary loss. And you see examples in the image. Finally, we perform a quantitative analysis where we measure capillary density, we look for avascular areas, and measure diameters of enlarged capillaries. Here we have an example of qualitative assessment of one of our DADA2 patients compared to the healthy volunteer. The healthy volunteer is on the right, and he has multiple small capillaries. Very different picture from our DADA2 patient, where we see a decreased number of capillaries, but capillaries that are larger and they appear engorged with blood. Our semi-quantitative and quantitative analysis of this test is still in progress. The next test is the laser speckle contrast imaging. It's a fast, full-field, relatively simple imaging method that is used to determine blood flow and perfusion in biological tissues. It is based on the principle that the backscattered light from a tissue illuminated with coherent laser light forms a random interference pattern at the detector, what is called the speckle pattern. The movement of particles inside the tissue causes fluctuations in the speckle pattern. Here we have the laser with a diffuser, the camera that brings the image to the processor to generate the speckle pattern that we see in this healthy volunteer in the hand. Good perfusion is represented by the red areas, while the areas that are less perfused are the blue ones. I find very useful this image where we have a comparison of the video capillaroscopy with the laser speckle. On the top of the image, the first panel shows the video capillaroscopy and the laser speckle in a normal volunteer. We see nice capillaries, normal number, normal morphology, and good perfusion of the hand. In the subsequent panels, we have different stages of the disease of systemic sclerosis, the early, acute, and late phase, where we see the change in number and morphology of the capillaries that corresponds to a progressive decrease in the perfusion of the hand as assessed by laser speckle. And here an example of our patient, the same patient we observed the video capillaroscopy. We have the laser speckle of the hand that is mostly blue, so less perfusion, with the only area that gets perfusion and red in the center where there are the two remaining painted vessels. And here a zoom in of the nail fold of the patient to demonstrate, again, the poor perfusion of the hand. I will then talk about the endothelial pulse amplitude testing, or EndoPath. This is an FDA-approved non-invasive technology. It captures a bit-to-bit plethysmographic recording of the finger arterial pulse wave activity with pneumatic probes. It provides a measure of endothelial function and arterial stiffness. The method is highly automated, consistent, and operator independent. In the image here, we see the probes on the hands of the patients. One arm is the control arm, and the other is the test with the blood pressure cuff that will be inflated to cause ischemia. Here we have the representation, normal flow until there is the occlusion, and then the reperfusion phase. In the control arm, the perfusion is continuous. The EndoPath gives us evaluation of the vasculature through two indexes mostly. The reactive hyperemia index that represents the increased blood flow and vessel dilation in response to occlusion. The reactive hyperemia index correlates well with endothelial function. And here we have in the table and in the graph our patients. Here in the graph, we have a line that indicates a normal cutoff threshold of 1.67 that was established in healthy volunteers. And we see how 3 of our patients are below this cutoff, while 3 of the patients are above, and one patient is borderline. Please note that one of the patients could not be recorded as he did not tolerate the test. The other index that we evaluate with the EndoPath is the augmentation index. This does not look at flow, but at pressure changes at the fingertips due to the arterial pulse. And this augmentation index correlates to the peripheral arterial tone, the arterial stiffness. Note that lower augmentation index values indicates better arterial elasticity. Here we have represented the ranges of normal stiffness being the more negative number between -30 and -10, increased stiffness between -10 and 10, and abnormal stiffness more than 10. Again, we have the table and the graph. And we have 2 of our patients that are in the normal range. 4 patients are in the increased stiffness range, and 1 patient is abnormal. Again, 1 patient did not tolerate the study. The near-infrared spectroscopy, or NIRS. This is an FDA-approved non-invasive technology that uses an infrared spectroscopy monitor to assess the tissue oxygenation in the deeper tissue, that is the muscle, but also the brain. The monitor, combined with a pressure cuff occlusion, it shows the rate of deoxygenation and reoxygenation of the tissue. The method is highly automated, consistent, and operator independent. And here in the figure, you see the sensor placed on the forearm of the patient with the blood pressure cuff proximal to that. At the NIH, we place the sensor on the cuff. Here is the graph with the results from a healthy control. In this graph, we find all the numbers that we find useful from the NIRS, starting from the baseline oxygenation as relieved by the monitor. Then, when the cuff inflates, the arterial flow stops, and we have the rate of deoxygenation with a minimal oxygen level when the cuff deflates and the arterial inflow resumes, and we have the rate of reoxygenation to the maximum level of oxygen, as well as the time to reoxygenation. When looking at our patients compared to controls, we have these findings. The DADA2 population study is represented by the orange dots, and the controls are the blue dots. We see already a difference at baseline in the tissue oxygenation being a little bit higher into the DADA2 population. When we have the inflation of the cuff, we then see that the DADA2 population compared to control is slower in deoxygenating. And then the real difference comes with the rate of reoxygenation. We see a significant difference here in the DADA2 patients compared to the controls. That is reflected also in the reperfusion time that is significantly longer, almost doubled in the DADA2 patients compared to the controls. This constellation of findings suggests that the DADA2 patients have a reduced ability to vasodilate in response to hypoxia. This may be because they are already maximally vasodilated at baseline, or because they have reduced sensing of the hypoxia, or it may be because of increased stiffness of the vessels. The last exam is the eye evaluation. This was performed to have available 1 more vascular bed to analyze, with the retina being particularly important because it's an integral part of the central nervous system that we know being affected by the DADA2. On the eye exam, we had no patients with visual symptoms. All patients had normal central acuity, normal visual fields, normal optic nerve, and retina exam. When analyzing the vessels of the eye, the fluorescein eye angiogram and the OCTA were also found to be normal. In summary, we chosen a battery of tests to evaluate the vascular abnormalities present in DADA2 patients, pointing towards the small vessel studies. And based on a small number of patients, preliminary data suggests an impaired vasodilator response. Keep in mind that this is a pilot program. It's still open to recruiting, but also open to further tailoring of testing based on our preliminary results and input from the scientific community. Thank you.